Welcome to Law and Justice. I'm Jane Mulcahy. This is a special series on the topic of how to talk policy and influence people. And today I am really looking forward to talking to Peter Krykant. How are you, Peter?
I'm good, Jen. Thank you. Thank you. And thanks for asking me to come along and take part. It's really a pleasure.
Well, I'm really looking forward to hearing about why you've decided to run for political office in Scotland, Peter. But before we get into that, maybe you can tell me just a little bit about yourself and your background and your career path to date, please.
Yeah, my name's Peter Krykant. I'm 44 years old. I suppose a lot of people wouldn't describe my traditional trajectory through life as a career path. Um, at a young age, I suffered quite a lot of trauma. I was in environments where I saw a lot of violence. There was a lot of drugs, a lot of alcohol growing up around. The environment that I grew up in. That all seemed like a normal thing to do. I thought when people drank alcohol that they drank to get they drank alcohol to get drunk, because everybody that I seen that drank alcohol, got drunk. And that kind of led me into a career path of drug addiction.
Okay.
That was my career path for many years. I started taking drugs at a young age. I was 11 years old, smoking cannabis on a daily basis. And by the age of 17, I'd been through the range of all drugs, alcohol, benzodiazepines, diazepam, the whole range, amphetamines, ecstasy, and then heroin at the age of 17. And that when that came along, that was something that I just took to like a duck to water. It was injecting from day one. I didn't smoke heroin. I just injected it. That's what the other people were doing, and it blocked everything out. It gave me a sense of release and freedom from, I suppose, all the abuse and all the trauma that I'd suffered. All that stuff had built up, and that just let me escape from all that, and from then on, as I say, my career was injecting drugs. I ended up leaving Scotland a couple of years after that, ended up on the streets of Birmingham, in and out of homeless accommodation, sleeping rough. As soon as I got to Birmingham, crack cocaine became a thing. It wasn't a thing back then, 20 odd years ago in Scotland, but obviously it was. It was very common on the streets of Birmingham at that point. I went straight to injecting that as soon as I got to Birmingham, so that just put more stuff in my
into you.
Yeah, exactly. It was just one of those things that made life even more tough than it already was. When I was purely had this like heroin addiction, 20 or 30 pounds could get me through a day. Crack cocaine was like never ending. It was like as much as I could physically get. So 3 years of that, and then I was fortunate that Birmingham Rough Sleepers team got a government grant to directly support people who were homeless drug users. And I was fortunate again to get sent to a really exclusive treatment centre called the Princess Diana Treatment Centre for Drug and Alcoholism. And that was like a world opened up that I never knew existed. We would sit in groups and 10 people, and there was some celebrities in there, and this guy would come down and every day he would come down to group in some sort of velvet dinner jacket, to have groups. And I'm sitting there like 6'3", 8 stone, covered in holes, body lice, just completely broken. With all I turned up with was a black bag with a change of clothes in it, but it opened up a new world, and I ended up going to Brighton. I got secondary rehab down there, and from there, that's when work careers and other things started to come in, and I got my first job in 2005, which I stayed at that organisation for 8 years. Then I met my wife and got married, got 2 wonderful young children now. age 9 and 5, and 2 dogs in a house, and all the stuff
All
that
the
comes.
trimmings. Yeah, all
Yes,
the trimmings
yeah,
of
exactly.
normality then. Yeah.
Yeah, exactly. And obviously, there's been struggles over the years, and I've had to address, for me, I've had to address those underlying issues and the things that led me down
Mm-hmm.
that path. Many people that I grew up with, Jen, we all took drugs together. We smoked hash, we went partying, we went to the nightclubs, we took ecstasy, at 15, 16 years
Mm-hmm.
old. But most people, the majority of people that I took drugs with and drank alcohol with, just sort of got to a point in their life where they moderated or
Okay.
stopped altogether,
Mm-hmm.
and went on and had these lives, in their 20s that I just started to experience in my 30s, because I had, 10, 15 years of really chaotic drug use.
Mm-hmm. Well, it's a harrowing story, but ultimately quite a hopeful one for people who are not doing so well right now, maybe, because what it shows is that recovery is possible, and that people can go on to do wonderful things and have fulfilling relationships, and make the life maybe for their kids that they never had themselves, which is a beautiful thing. But so I know you from Twitter, which is where I find so many great people these days doing tremendous work. And I saw there, I think it was on New Year's Eve, that you decided to run for political office. I'm sure it was something you were mulling over for
Yeah.
longer than Christmas time. But how did that come to be, Peter? Why did you decide that you were going to throw your hat in the ring and maybe become a politician?
Yeah, it was it's been a process, it just came out around about the end of 2020 that I would actually put myself forward to run for political office. But it's been a process. I suppose one of the driving factors behind that has been my wife. She's always said that I should do something like this. Obviously since I became a bit of a public figure in terms of drug policy reform, all the feedback is that I do really well in front of media, that I can handle the cameras and the publicity, and I can continue to actually present a clear and concise message of what we need to do in order to change drug policy, in order to keep people alive. And I have a background of being interested in politics, and a background prior to getting involved in and working with people with drug and alcohol problems. I worked in business, so I have a sense of what we need to do in order to really engage our communities. And I think that's what ultimately drug policy and stopping people dying in Scotland in years to come is about: engaging local communities. It's about investment in education for our children around alcohol and drug issues. It's about giving kids stuff to do in the communities, and providing jobs for people so that they have employment and they're not in these socially economic deprived areas, which are a breeding ground for people who are going to die from drug deaths. And that's the reality. We know that there's that demographic of people who are dying from specific areas. That data is all there. We can see that. And to really tackle this over the next 2 or 3 generations and get us to a point where we're not seeing Scotland topping the charts for drug-related deaths, we've got to tackle it at the root. And at the root is normally trauma, is normally people who are really struggling, and trauma can come in so many different forms. It's not that often that parents are always just being bad to their kids, or hitting their kids, or sexually abusing their kids. It's sometimes the fact that parents are working full time, but they still have to claim benefits. I mean, have you ever heard of anything so ridiculous that somebody's out working 40 plus hours a week, but still having to claim top up benefits from the government, and then they can't feed their kids, and their kids are there's malnutrition because they can't feed their kids properly, they can't provide for their kids, so therefore the kids start to suffer these traumatic experiences, which are relative to each person, so.
Indeed. And can you just tell me a little bit about Scottish drug policy at present? what is the kind of dominant discourse around drug addiction? And like, do politicians kind of understand the traumatic underpinnings for most addicted humans, or do they think it's a matter of choice and it's a bad choice that people freely decide to take these horrible substances that wreak havoc in them and their communities? And you mentioned the drug deaths there. And Scotland, unfortunately, has had an awful lot of them. I mean, we have too many ourselves here in Ireland. But, you know, are you guys being mobilized? During the pandemic, of course, it's more difficult as well to actually reach people. But are we doing enough in your country to tackle these awful deaths?
Yeah, I think, generally speaking from a Scottish perspective and looking at Scottish politicians and Scottish government, I think there is an understanding of the links between, you know, adversity and trauma and poverty and you know, that deprivation, the higher level areas of deprivation, the links to that, and then the links to problematic substance use, and then obviously the links to death. I think there's an understanding of that, and I think there's a lot of well-meaning politicians out there who do genuinely just want this to you know, us to get some handle on this and to see the drug deaths obviously coming down and people not dying. But I just think there's a real lack of understanding of what we need in terms of policy to make that happen. You know, there's been a lot of talk in the Scottish Parliament and from the recent public health minister, who is no longer in post, around stigma. You know, and stigma being this big killer, you know, and stigma's terrible and stigmas shouldn't happen, you know, and we should try and move away from that. But let's get it right. Stigma's not killing people. Underfunded services, services that are unable to attract people in and unable to retain people. I mean, Scotland has under 40% of people with problematic substance issues in any form of treatment, under 40%. And if you look at that in comparison just to England and Wales, it's over 60%. Now that's the biggest killer. You know, like we could have overdose prevention sites all over every single public injecting site in Scotland, and it's not going to make a massive impact unless we can get the people visiting the overdose prevention centres into treatment, because they're still going to use outside those overdose prevention centres. You know, so it's getting people into treatment, and it's very simple, some very simple steps that we can take. I mean, to try and keep this very basic for anybody who's listening who doesn't understand the setup in the UK. If I'm a heroin addict and I live in Birmingham and I want support and help, I go to the third sector organisation, which is Change Grow Live. They're the drug and alcohol support organisation. They assess me and then they give me a substitute prescription. If I do that here, where I'm from in Forth Valley, Change Grow Live also operate here. If I go to them with a heroin problem, they assess me, but they cannot prescribe. Oh,
right. There's a legal barrier.
Well, there's not a legal barrier. There's just a barrier that's in place that could be easily removed.
Okay.
They've got the third sectors like Change Grow Live here have got to assess me and then send me to the NHS prescribing team, the alcohol and drug teams within the NHS, because they control all the prescribing. So it's another assessment.
Yes.
You're talking to a chaotic drug user whose whole focus every day from the moment that they wake up is to get money to get drugs. To get to one assessment's tough.
I guess,
if you get to 2 or sometimes 3 assessments before you even get a substitute prescription, the chances are it's just never going to happen for you. So there's simple things. All we need to do is give Change Grow Live, We Are With You, the third sector organisations a little bit more money to employ prescribing, non-medical prescribers. They can assess people and then they can prescribe to them. And what also happens there is you lose the risk adverse policies of the NHS. And the therapeutic guidelines for a therapeutic dose of methadone are between 60 to 120 millilitres, but you start on 30 and then you titrate up to your therapeutic dose. In Scotland, if you need to get from 30 to 90, that'll take you 6 weeks, because they'll only titrate you 10 mils a week.
Okay.
Down south, where the third sector does it, they'll titrate you every 3 days. So it's less than half the time in England to get to your therapeutic level than what it is in
Very
Scotland.
interesting. And
Yeah.
what do you think the resistance is? Is it fear? Is it just about being risk averse and not wanting to give people too much, afraid that they might contribute to a drug death maybe? Or is it not understanding the problem, really, not understanding the process of addiction for people, that they need help, managing the actual addiction itself?
Yeah, it's a really difficult one, because, like, as a layman, this seems such a simple, straightforward solution to get more people into treatment and to get them to the therapeutic dose quickly. And if it's not been seen before, I'm thinking, who are all these experts on drug death task force?
Yeah.
Who are all these policy ministers, and what are they actually looking at, and what are they doing? Because this is a very simple solution to get people into treatment and keep them in treatment. And I don't know why these sorts of things have not been looked at or not discussed, or if they have been discussed, we've just not had visual to that, or we've not been party to seeing that, because it's all done in this very small bubble. The drug death task force that was set up with Joe Fitzpatrick, that was chosen with 23 people, one person who had lived experience on the original task force, any experience of drug use. And I know that person personally, and he's a really nice guy, but his drug use experience is not from the types of drugs that are primarily killing people. The ones that are mostly killing people. You need to choose somebody to go on those types of task force that has experience trying to access the services that are currently running. That has experience of the drugs that are primarily killing people, like heroin and benzodiazepines. Those are the people who should be getting included within these task force. And then, to be honest, we don't even need a task force. That's been the biggest farce that's went on in Scotland, is this task force, because there's simple, straightforward solutions to get a handle on this drug death crisis that we're facing, that can be implemented overnight.
Yeah, it's so interesting that you mention the one person there with lived experience, because it's come up throughout my talks in this series. The value of listening to people who know what they're talking about, from the kind of the gut, from the visceral level of what it means, and even, as you say there, the difficulties getting from A to B if you're in drug related chaos. But one of my interviewees, Rebecca Lewis Pankratz, has a saying that those closest to the pain need to be closest to the power, or whatever the problem is, need to be closest to the power. So it would seem really that at least half of any task force should be people with lived expertise.
You would think.
Yeah, because now they may not all agree either. Perhaps that might, cause.
That's the thing, though. Joe Fitzpatrick chose this task force, and there was one person with lived experience. There was a massive fuss about that. Lots of people kicked up a big storm about that, and then 3 more people were added. But he got the advice of who to add to that task force from the same person that he got the advice from the original person. And it's still an outnumbered equal. It's not an equal representation. And we've got so many professionals in the field now who have got experience of things like opiate-based intravenous drug use, benzodiazepine, methadone. We've got so many people who have got professional experience working in the field now that there's not any excuses why we're not getting seats at the table. There's no excuses, and that's why I tend to take my fight to Parliament, because I will be the first ever candidate who's openly ran as somebody who's got direct experience of intravenous drug use, homelessness, trauma, and I have no illusions that I am running against the party political machines. The SNP are parachuting this woman in who doesn't even live here, who will have leaflets going out to every single house in the Falkirk East area, you know, probably double leaflets, one at the beginning of our campaign and another one just before the election. You know, I've got no illusions that it's going to be a tough task to get into Parliament for somebody like me. But I'm going to fight tooth and nail to get there, because we talk about representation in political spheres often in terms of, you know, we need representation for people who are disabled. And there is some representation in the Scottish Parliament for that, but there's never been any representation for the tens of thousands of people who suffer from drug and alcohol issues. You know, so I hope to be that first person.
Yeah, I hope so too, Peter. I think you'd be a great addition. Can you tell me what your kind of the people that you know in drug related circles, you know, people working in outreach and in treatment, and you know, I know James Docherty and other people in Scotland who've got addiction and trauma histories too, and a lady, Natalie, I think it's Logan, who runs the Recovery Cafe with prisoners and this type of thing. Have you gotten encouragement from people, you know, I presume you have, other than your wife, who kind of are saying, go Peter, we're in your corner?
Yeah. It's a difficult one, you know. Obviously, from a professional point of view, many people are in positions where, you know, it's difficult for them to publicly support. And we also have this sort of schism, you know, like this sort of divide, or this harm reduction versus recovery type argument going on in Scotland, as if one's more important than the other, you know, which is absolutely insane. And I come from, certainly, like I was saying to you earlier, from this background where if you'd been asking me these questions just 2 years ago, I'd have been giving you completely different answers. Right. You know, because I really thought that the biggest answer was residential rehabilitation to solve the drug death crisis. And now when I say that, I kind of laugh at myself saying it, because that's what I really thought 2 years ago. You know, and it's absolutely 100% not the case. I mean, residential rehabilitation needs to be a part of what we do, and we need to do it well, and we need to look at the evidence for the best residential rehabilitation centres, so that we can make use of them when somebody's at that point of being ready to explore abstinence-based recovery. You know, but to think that that's the main answer is absolutely, in my opinion now, not the case. People cannot recover if they're dead. You know, I'm alive. Yeah, you know, I'm alive today because of harm reduction. You know, I have somebody who directly was administered naloxone, you know, the opiate reversal, opiate overdose reversal drug. You know, without being administered naloxone, I wouldn't have any of this what I've got now. I would never have been in with a shout. You know, and overdose prevention centres are, you know, for me, one of the key responses. We can, anywhere where there's public injecting, we should have an overdose prevention centre, because it's a health response. You know, it keeps people alive and it keeps people safe, but it also engages people into treatment. That's the key there. So yeah, I mean, there's been support from like the likes of people that you mentioned, and a lot of people support me privately. The public support hasn't been like massive. But I think although in many ways the people that you spoke about there are thinking as aligned in some aspects, my thinking's changed very, you know, a lot in the last couple of years from where it was 2 years ago. I get more support from the harm reduction. You know, the people that have been out there asking for more harm reduction. You know, I seen something on Twitter recently, and it was essentially that we need to stop focusing on harm reduction. You know, and we need to look at more residential rehabilitation. I think we're getting that the wrong way around. We need to look at more harm reduction and more residential rehabilitation. Why would you put one down for the other? Both are key, you know.
Well, one thing that I found amazing, as someone who knows little about this really, but, you know, I've researched prisoners and pretty much all of them have addictions, you know, 80 or 90% in Ireland, combined with often mental health problems. to do with the poverty and trauma mashup that you were discussing earlier. But in Ireland, to go to treatment, you have to pay for a bed as well. And so if you're on social welfare, your social welfare has to go towards paying for the bed. I had always presumed in my naivety, if I wanted a treatment bed, I could just get a treatment bed because society would have an interest in my recovery, you know, but that's not the case. There are only so many treatment beds. But then I was reading Johan Hari's book, Chasing the Scream, and I found it so interesting, just, you know, looking at the Portuguese model and the approach elsewhere, and how really we need a continuum of services and ways of getting people into a healthier, safer space. And so, and in Switzerland, they have loads of these injecting centers where you can get other treatment and access to work and all sorts of things. But it does seem that people can have sometimes, unfortunately, ideological differences where it has to be all or nothing, or one or the other, as you say, kind of splintering support then for what is essentially the same cause and the same goal. But just for people who don't have a clue really about addiction, which is lots of people, including many lawyers and judges, can you just tell me a little bit about readiness for treatment? Because from what I heard in my own research, people have to really be ready for it to work. Or would you agree with this? Like, say, to enter residential treatment anyway, for example, if you're chaotic heroin user who really is in so much pain that the idea of giving it all up is not feasible. You know, it has to be a gradual process. Or am I confused about that?
I mean, I can only really 100% go from my own experience. I mean, I was 23 years old, you know, living homeless, sleeping rough, in and out of homeless accommodation for about 3 years when I was sent to this residential rehabilitation centre. I had no idea what I was getting into. You know, I just thought, you know, I can't keep being on the streets. You know, I'd been on the streets for quite some time at that point. And, you know, I turned up there and they kind of, it was like an enforced abstinence. You know, it was like, you know, you get your detox, but all we're going to bombard you with for 3 months is that you need to be abstinent. You know, you can't drink at all. You can't take any drugs. You know, and I've turned up at this place thinking, you know, I just don't need to take heroin and crack cocaine. You know, and
right? Okay. Everything
you know,
else is fair game.
Everything else is fair game. You know, it's like I had only took heroin and crack cocaine for, you know, probably 5 or 6 years prior to turning up to being admitted to this treatment centre, you know, and I didn't understand anything about trauma and the links to addiction. You know, I'm 23 years old, my whole life has been consumed by drugs up until that point from the age of 11. So I didn't go to this, you know, really expensive treatment centre with lots of celebrities and people like that, and then leave a few months later and my life was sorted. You know, like I went back to drinking, I went back to taking drugs, you know, a periods of time when I stopped and I started, you know, and that was probably the most dangerous times for me, you know, because I'm out of this, coming out of these establishments and I'm abstinent and, you know, I've got no tolerance levels. And that's probably the most dangerous time for people dying from drug deaths when they come out of prison or they come out of, you know, residential rehabilitation centres. You know, I think residential rehabilitation centres are absolutely fantastic, but I think we need to, like Johan Hari talks about, you know, the opposite of addiction not being sobriety. The opposite of addiction is connection. You know, and I think what we need to do first and foremost through harm reduction is create connection. You know, through the harm reduction, inviting people into overdose prevention centres, you know, getting people onto opiate substitutes so they don't have to take the really dangerous illicit street drugs, benzodiazepine substitutes, and engaging with them while they're stabilising on those, you know, and creating that connection with somebody, you know. And if we build that connection, we can then at that point get them into the opposite of addiction before they even start, before they've even
Yes.
stopped taking drugs. You know, you don't have to stop taking drugs to be in recovery, and that's the thing that I suppose grates on me a little bit. You know, that from certain people, recovery is all just about abstinent, being abstinent. You know, and if you're not abstinent, you're not in recovery. And I think that's really demeaning to the people who are trying really hard to stay away from illicit street drugs and continue to be on medication. You know, like, because that's all it is. It's a health issue. Methadone's a medication. You know, benzodiazepines are medication.
Yeah.
You know, these are all medications. You know, and it's like saying to somebody who develops diabetes, you know, like, you're not in recovery until we, you know, stop your diabetes medication, and it's like that's going to kill them. You know, and that's the
Yeah.
same thing. You know, that's the same thing with taking somebody's period of stability away from them really quickly, and then throwing them into this, you know, you and I both know, this big bad world where, you know, things come at you left, right and centre from society, and the way that the society is, that sometimes is really difficult to cope with. You know, so I think I was very blinkered in my own abstinence-based recovery up until just a couple of years ago. You know, my first job was working in a recovery community. My first job in the sector was working in a recovery community, and the main message there was that, you know, for people who would come who were, you know, really still using drugs or drinking alcohol, the message would be that you're not welcome here.
Right.
You know, you can't come here. You know, you smell of alcohol, or you're stoned from, you know, whatever drug it is, so you can't be here just now. You know, I'd have to turn those people away. And it was only really working in that recovery community and through reading things like Johann Hari's Chasing the Scream, you know, and looking at the work that Release Drugs, Transform Drugs Policy Foundation, and some of the work that SDF have done, and, you know, some of the work that's been done around harm reduction and other areas around the world, you know, that my eyes started to open, that recovery means so much more than just being drug free, you know, or clean, which is a word I don't use these days. You know, like I don't use that because even within drug-free, abstinence-based worlds, it's like, I think we need to think about the language that they're using. I was never a dirty person. You know? I was just a person who found that drugs and alcohol took me away from the trauma that I had experienced. You know, so so that's my thinking around that stuff.
Yeah. As you were talking there, I was just thinking about Stephen Porges, who was this guy who developed polyvagal theory, but I interviewed him before and did training with him. He's a fascinating guy. And he says addiction and mental health issues really are neural state disorders. So that our inner felt experience of the world has been disrupted somehow by fear and often by trauma, you know, or community violence or whatever. And in order to feel safer in our bodies, then we take whatever we take, you know, to try and dampen down the arousal, or to lift if you're really, really low, you know, and to feel something, to feel alive. And then I like as well Gabor Mate's phrase about, you know, we should stop pretty much asking why the addiction and ask why the pain. From your experience of drug treatment services, you know, are most of them trauma informed? Do they look at these type of things, or don't they?
I mean, it's a really difficult one. I mean, when you consider that, what I was saying earlier, less than 40% of people are in any form of treatment in Scotland, and we already hear from the services that deliver the support that they're overworked and understaffed. And that's with so little people in treatment. If we can actually get another 20 or 30% in Scotland into treatment, the only way that that's going to work is if there's more people to actually do the jobs. Because right now I hear stories, and I have over the last couple of years, that people go to appointments where they should be getting this like social psychological therapeutic relationship, and connection that you had. Harry talks about it, and they basically get 20 or 30 minutes and then they get rushed out the room because the workers got to actually write up the notes and then be ready for the next person coming in. So they don't even get an hour, they get 20 or 30 minutes. The workers are away madly typing up the notes, and then it's right into the next meeting. So I think we always emphasize this trauma informed, but there's massive difference between trauma informed and actually trauma practice and how you actually do it. And I think that's where that link's missing. I mean, I think Gabor Mate talks something around the lines of it's not about a war on drugs, it's a war on people. I think something along those lines, but I'm not sure if it's Gabor Mate or
he has said something like that. All right, that the people who are most vulnerable and on the margins, including say indigenous communities or people living in very poor, under stress communities, are most represented. Would you agree with that as well? The poverty trauma link, in terms of the friends of yours who outgrew kind of recreational drug use. Do you think the difference between you and them was the trauma? Or is it hard to say?
I think in some ways, I think certainly I probably experienced a bit more closed trauma, than certainly a lot of my friends and my peers that I grew up with. There was a lot of behind closed doors trauma that they weren't seeing. You can never tell what somebody else's household is like within that house. But yeah, I mean, it's a difficult one because addiction is also not something that just affects people with traumatic experiences and backgrounds. I know people that have had real difficult problems with drugs like heroin and crack cocaine that would say that their upbringings were from loving, caring families, and they didn't experience divorce or abuse or sexual trauma or anything like that, growing up. This ACEs stuff that you hear a lot of, they would only maybe have a 1 or 2 score on it, which I think is pretty normal for people who have never had traumatic experiences in childhood. So it's not, it can be, a case of it's not something that's only one specific area, but I do think people from poverty and traumatic experiences are more likely to do that. But then there's also the link to things like obesity, and there's all various different ways that people can sort of self-punish in terms of self-harming and stuff as well. So yeah, there's links there for sure, but we need to cast the net wider in terms of supporting people, because we often hear about decriminalisation. And my opinion on decriminalisation is that that's absolutely fantastic for the 90% of people who use drugs where they have no issues or problems. The guy who likes to smoke a little bit of weed now and again, doesn't get a criminal record for having, a £10 bit of cannabis in his pocket and getting, pulled over by the police because of it, or the person who likes to have the odd line of cocaine when they go out to a nightclub doesn't get a criminal record because of that. So the 90% of people who use drugs where there's no problems, decriminalisation is great. The only way that decriminalisation would work for the 10% of people that have all these problematic issues with them is if you take the money that's saved from criminalising people and put it into treating it as a health issue for the problematic. It's the same as alcohol. Most people who drink alcohol doesn't create lots of issues, but we need to properly support the people that it does. So decriminalisation on its own, we could decriminalise drugs tomorrow and it's not going to stop people dying from it unless we treat the people who need the support.
Sure, we need to just get real about what's at stake, I suppose. And so in terms of the exiting or starting to get healthy, get safe, get healthy, and maybe go into recovery, or eventually, you know, stabilize on methadone if that's necessary, maybe go into addiction treatment in a residential setting. Is there a role for the wider community in helping people sustain recovery?
Yeah, I think you know, the role for the wider community and the wider public is about less stigmatization. You know, I think we need to continue to talk about addiction as being a health issue, you know, in the wider communities. I think what we're seeing now, certainly in Scotland, that you know, it's changed so much in the last 10 or 15 years. Certainly, I have this perspective that it's changed. I don't know if it's my algorithms on social media, you know, that I only see the positive stuff. But even when I search through like online social media platforms to look for like a story from BBC, and then you look through the comments and stuff, it seems like the majority of people understand that this is a health issue now. You know, even like in Glasgow City Centre, where I was taking the overdose prevention van, initially I was like, oh, what's going to happen here? Is all the business owners going to go mental? You know, they all going to like go nuts, or all the residents going to come out and chase me away with big pitchforks or something, you know, like. And that's what I'm thinking the first day I'm driving into Glasgow with this, you know, this wee transit minibus, saying I'm going to let people come in and inject heroin in it. You know, I'm thinking, what's going to happen? But the response has been absolutely fantastic. You know, like the businesses have been really supportive. Local residents have been really supportive. They can see what is the point in giving a homeless person clean injecting equipment and then giving them nowhere to actually use that. They're going to use it in the alleyway next to where the pharmacy is. They're going to use it in communal entrances to people's houses, where they can get a shelter, and parks and car parks. They're going to, you know, get infections. They're going to get, you know, HIV, which is, you know, currently the largest outbreak of HIV is ongoing in Glasgow City Centre amongst people who inject drugs. And we've never seen an outbreak like this for 30 years. You know, and an overdose prevention centre in the city centre would stop that, you know, because people are in a clean, sterile environment. You know, they wouldn't be sharing equipment. So, you know, these centres now are, there's no logical reason against them, but they're only a small part of what we need to do. You know, the biggest thing, you know, to not sort of repeat myself too often, is to get people into treatment, get people off of illicit substances and into recovery.
Yeah.
And that's getting them onto methadone, getting them onto substitute prescriptions. That's the first step in being in recovery. As soon as we get people off of illicit drugs into prescribing of medical drugs, they, in my opinion, are then in recovery. And if we can, as a recovery community and as a person in abstinence-based recovery, if I can encourage other people in abstinence-based recovery to see that somebody doesn't need to be abstinent to be in recovery, my goal would be accomplished, because I thought like that just 2 years ago.
Yeah, that's really, really interesting. And we have to be open to the evolving knowledge or evolving experience, you know, with people, because we're all works in progress, I suppose. And to be denied opportunities of help when we ask for it, I think must be very difficult, you know, because surely addicted humans get rejected a lot. So a rejection at a point when you really feel ready, and then being told, no, come back in 3 months, clean and sober, you know, with a load of spotless urines, and then we'll talk to you, must be challenging. And yet, though, for people, I suppose, who are in early recovery but might be easily influenced by the energies or dysregulation and addictive behaviors of others, it's a tricky balance, I guess, you know. I don't have to make the decision, so it's easy to express an opinion. But Peter, can I ask you one more question about crime and young people who are at risk, I suppose, of maybe engaging in drug use or drug dealing or gang-related violence, and kind of behaviors that have a very negative impact, not just on themselves, but on their wider community. Can you think of any ways that we can better deal with that type of a problem?
Sorry, repeat that question again, Jane. I've got the basis of it.
But... Well, just for young people who are at risk of or are already involved in drug dealing or drug taking and gang-related violence, maybe, especially in poor communities where it might be the only way of making money, actually. Can you think of any more effective ways, I suppose, of helping these young people reach the potential that they have, but also just living a safer, healthier life?
Yeah, I mean, I think that's why I'm running for to be elected as a politician, because I think we have clear ways to do that. It's investment in our local communities. You know, it's providing education to kids around the, you know, alcohol and drugs in the school curriculum, making that a part of the curriculum. You know, and then education, further education, and then getting jobs for people. You know, that's the basis of how we stop people falling into that, because I see just now that there's 15, 16-year-old kids, sometimes even younger, running about Glasgow all day on mountain bikes and selling Valium, you know, at that age. And that's how they make money, you know, and they see these other older guys who are, you know, criminals with big gold watches and driving fancy cars, and you know, obviously they're looking up to them, and it's like a revolving door. So it's the only way we're going to break that is getting education into the schools, getting investment into the local communities, giving kids stuff to do that's you know, rewarding for them, rather than just being driven to make money. But also, I mean, the bigger, longer term, you know, is a full regulated and legal market for all drugs.
Right. So you favor legalization, do you, Peter? Or regulation?
Regulation and legalization for all drugs. I mean, that's a way down the line. I mean, we at this point, I would be happy to decriminalise drugs and put all the money that's saved from sending people to prison into supporting the 10% of people who, you know, use drugs problematically. But Transformed Drug Policy Foundation wrote a book at the end of last year. It was released, and it was called Stimulants and How to Regulate Them. And it's a really interesting book. I mean, when we talk about, and Professor Alex Stevens does a TED talk about, and it's progressive legalization, he calls the TED talk. So I would definitely recommend that book and that TED talk. So, you know, progressive legalization is talking about starting with decriminalisation, and the Transforms book raised so many questions for me that I hadn't really thought about before. Because if you do just have this like fully regulated market where, you know, that you can buy things legally rather than illegally, you know, you can obviously control what's in substances, so then you people know exactly what's in it. Yeah, it's safe for everything. Everybody knows what's in everything. Like when you go to a pub and buy a pint of alcohol, pint of beer, you know how much alcohol's in it. You know, in Prohibition America, when you bought a pint of moonshine, you had no idea what was in it. You know, it was just like random. You know, one pint of moonshine could have 40% proof alcohol, and the next one could have 4% proof alcohol. You know, because you don't have any clue. And that's the same with Prohibition now with drugs. You know, so but when we legalise and regulate the drug supply market, what we then do is we disrupt a multi-billion-dollar industry. You know, we disrupt the farmer in Afghanistan, the farmer in Mexico, who are farming just to feed their families, and the people who are working there are just working there to feed their families. You know, and we disrupt that all the way through all the cartels who are controlling it, all the way to the street level dealers in countries like Ireland and Scotland. You know, the street level dealers, they all lose their jobs.
Yeah.
So there's a lot to think about
There is
before,
a lot to think about. Yeah.
we go down that sort of full-on progressive sort of, regulation route. And I think decriminalisation is something that is going to happen to begin with. And then when we decriminalise, we can actually support people, and then we can look at other avenues to make things safer again, to continue to make stuff safer, to continue to see less people dying, and organisations like Anyone's Child, some of the videos on their website, it's heartbreaking. Some of the parents that have stepped up in order to campaign for a regulated market, and particularly Ray from Transform, his video, he lost both his sons,
Dreadful.
to an illicit, uncontrolled substance, which wouldn't have been the case if it was regulated and controlled. So I take my hat off to those parents that campaign through Anyone's Child, and other organisations like Mums Stop the Harm, who are a Canadian-based organisation. Unfortunately, we don't really have that in Scotland. I don't know if Ireland has any of that, but that's one area that Scotland's lacked. Like, we don't have campaign organisations like Anyone's Child, like Mums Stop the Harm. We don't have drug user activist groups, and a lot of that is tied into the previous stigma, and a lot of it's tied into, criminalisation if you do have active drug user active organisations, and the stigmatisation for families stepping forward to say, actually, yeah, my son did die from a heroin overdose. I don't want other families to go through the same suffering and pain. We've got good organisations to support people in Scotland who have lost a loved one, like Scottish Families Affected by Drugs and Alcohol, but they're not a campaigning organisation. They're not going out there and saying, no, actually, the government needs to decriminalise and regulate this market. That's where we're lacking. What we're lacking in Scotland is those campaigning organisations.
Yeah, well, I suppose, Peter, if you get elected, then there'll be a whole pile more discussion of this on the floor. It's at Holyrood. How do you?
Holyrood on the 6th of May, and I'm running in the Falkirk East constituency, and I am campaigning to become the constituency MSP, which nobody thinks I could do. Everybody's saying, because there's
why not? You totally can.
There's this first past the post election process in Scotland, but there's also like a list election, which is like a proportional representation for regional, and everybody's, you should run for the region. I've even had people saying to me I should run in Glasgow or Edinburgh or whatever, and I'm like, why would I want to do that? My main message to the people who live in my area is, vote for me because I live here and I'll represent your views. I don't live in Fife where the other candidate comes from. It's I'm running against the party political machine, so I have no illusions that it's going to be a really tough fight, and I'm going to have to campaign really hard. But I've already started. I shop local, I buy local, I talk to local people, and once I've got my nomination forms in and I've sorted out all the spending regulations, I'm ordering 100,000 leaflets.
Okay.
And I've already looked, it's £1,400. There's 78,000 constituents in my area, and every single one of them will get a leaflet at some point.
Your smiling face
on your
platform.
Local, vote local, shop local, vote local.
No, it's smashing. Well, you're absolutely to be commended for, stepping into the arena, as Brene Brown says, because it's easy to have ideas and to complain and to say nothing's being done, but it's a whole different ballgame trying to do it, and to daring to be relevant and to get in there. So I'm so grateful to you for spending a bit of time with me today and telling me about yourself and where you've been and what you're doing and your great vision for drug policy reform. And I really hope the campaign goes well. And
thank you.
You get the seat, and even if you don't, it's well worth doing. It's amazing.
I think I'm going to give it my best shot, Jane, and thanks very much for having me today. It's been a pleasure, you know, and if nothing else, I'll highlight the drug policy campaign.
That's it.
And you know, reform and continue to do that, and hopefully I really feel this year we will get our first officially sanctioned overdose prevention centre in the UK. So that's still my number one goal, to get that done.
Okay, well, Peter, thank you so much. This is How to Talk Policy and Influence People with me, Jane Mulcahy, and my guest was the wonderful, brave and visionary Peter Krykant, running for political office in Scotland. Thank you, Peter.
Thank you.
Take care now. Bye-bye.